every freaking rock you look under in healthcare is another damn rattlesnake. People say healthcare is so confusing. I don't understand what am I getting for what I'm paying for? That is by design.
Yeah.
It's not broken. It's rigged. They set the wholesale price, they set the market price, they set the reimbursement rate, and then they fudge the numbers. The margins are made in the mystery.
Isn't the point of an insurance company to make their overhead lower, or are we missing something?
No, this is the dirty secret, because it's a shell game, and I'm going to show you how the magic trick's done.
I can't believe that police officers aren't just coming in as soon as you see that saying, whoa, hold on a sec. People are being robbed.
And that is how they've built the model. They're terrified. And it goes even deeper.
The deeper you go, the more they keep cashing in.
It's because the insurance company has built this system to delay, deny, and depose. Why is there a rise in chronic disease? Follow the money. Show me the incentives, and I'll show you the outcomes.
How would you fix it? Obviously, you've stared at the eyes of the dragon. How do you defeat it? Because it seems almost insurmountable.
Anything's better than what we're doing, which is nothing. If you put your health and your family's health in the hands of these big insurance companies, and you eat the average American diet, and you go to the average American doctor, do not be shocked when you die of the average American chronic disease. Yeah. That is what the system is built to do. You've got to take yourself out of the system.
Brigham Buhler, thank you for being on the MAHA podcast. Great having you here.
Thank you for having me.
Yeah, super cool. I've been running all over the country, as a lot of people know, and, catch little snippets of your story, but I've never really sat and gotten the whole thing. So I'm kind of like new in here. But like really where you start is pharmaceutical sales. Is that right?
Yeah, right out of college. Okay. I had the privilege of what I thought was going to be an amazing job. Right out of school, I got recruited by Eli Lilly to launch the competitor to Viagra. So
now, is that like the CIA? Do they come and look for you inside of a university? Be like, this guy's perfect to be a pharmaceutical
It is funny. So they
person?
recruited out of this sales program at University of Houston, and I was number one in the sales program. And interesting story. They were like, hey, if you can be out of school in 6 months, we're going to have this job opening. So I told this story on Rogan's podcast. Yeah. I ended up taking 24 hours in summer school, 24 hours a semester while working full time, graduated in 2.5 years to take what I had thought was going to be like my dream job.
Yeah.
Because again, I'm 44 now. So this was
right.
24 years ago.
Yeah.
And that was back in the day when you thought, pharmaceutical companies were helping people. Like I was still naive. I thought, man, this is going to be an opportunity to go out and really drive change and help people and learn new drugs and new medications that can change and impact people's lives. So I was excited about it.
Did you have any medical background at all?
No, not at all. No, because what happened, and this is interesting as we get into insurance, you'll understand how it all works. They used to hire pharmacists with in-depth, chemist backgrounds and the knowledge of the molecules where they could go deep dive with clinicians and explain what's going on. But as HMOs and insurance took over healthcare more and more, the days of a primary care having the autonomy and the freedom to like practice medicine are over. And they literally have 6 minutes with a patient. And so the drug rep job pivoted from a pharmacist coming in, rolling up his sleeves and talking about patient outcomes and white paper studies to hiring young, hungry salespeople. Oftentimes really good-looking girls that can come in fast, get the doctor's attention, give him a 30-second elevator pitch. So they didn't hire pharmacists anymore. That pivot probably happened in late 90s, early 2000s.
So it makes sense. They probably said, look, you're talking to regular people anyway. Why do you need all this science information they're never going to understand? Obviously not caring whether the doctor understands it. Let's just have the doctor understand only the elevator pitch, and that's what they'll deliver. And I would imagine sales increased at that point.
They absolutely did, because the goal changed. And this is the side of being a drug rep that I didn't like. So it was all fun and games when I carried Cialis, right? Everyone was excited. It was a new 36-hour Viagra, no real side effect profile. People were excited about the compound, and it was fun, candidly. Like right out of school, I'm like, man, this is amazing. But then after about 18 months, I got moved to SSRIs and antidepressants. And that was a market. I'm sitting even back then where I'm going, I'm asking the doctors that are training us and saying, well, wait a second, this barely differentiates from placebo. I'm like trying to understand, why would doctors prescribe this antidepressant if it's basically the same as placebo? And how is this even FDA approved? I just couldn't wrap my head around it.
How did you see that information? Was that a part of your training? Did they take you through placebo and all that stuff?
At the time, I don't remember the exact data, but it was like Prozac was at 50-something% efficacy and placebo was at 40-something%. And now jump forward to today, 75, in a retrospective analysis of 75 of the biggest antidepressant studies ever done, what we found is that the SSRIs never really differentiated from placebo. 85% of the efficacy is seen in the exact same placebo-controlled trials as it was in the antidepressant trials. Furthermore, 50% of people relapse within 18 months, increased risk of suicidal ideation and violent thoughts in the first 6 months of treatment. Deaths of despair at an all-time high, greater than that of the Great Depression. I think it's safe to say we were bamboozled. Like the medications didn't work. But in over 75 studies on the depression scale, what they found is it's literally a 2-point difference. It's a 2-point difference on a 50-something point scale. So from placebo.
From a trial done by the manufacturer itself. So they cherry picked like the absolute best data they could and still only beat it by 2 points.
And then that's the dirty secret that I learned as a drug rep. And I only did it for, the first 12 to 18 months I was Cialis and I was having fun. As soon as I moved to antidepressants, I just didn't feel ethical selling them. I didn't believe in them. And, exercise is 2.5 times more efficacious than any antidepressant on the market. But we don't talk about exercise and we don't educate clinicians on exercise or diet or lifestyle or any of these things that can truly drive meaningful change. What our job was as a drug rep was to grow in and grow the patient population. And so what's scary is I would have a list of all the doctors in my geographic region and how many antidepressants they wrote. And my job was to go in and convert them to writing my antidepressants or to write more antidepressants. And the messaging and all of that I saw, it's like this, they have these off-label, how they talk about on-label and off-label? The drug may be indicated on-label for these things. That's a certain patient population. If you're under pressure to grow your patient population, right? Now you start looking at where are clinicians using this off-label. And they would even bring in clinicians from around the country to talk to us about where they're having benefits using these products off-label. And then you're put out in the field, you sign all these paperwork on little online training programs that say, I won't promote off-label. Yeah, I agree, I won't promote off-label. Then why are you bringing clinicians in to teach me how to promote off-label and then setting me free into an environment to go grow a market share where you're essentially, it's a lie agreed upon is where I go with that. Like these pharmaceutical companies are 100%, at least historically when I was there, again, it's been over 20 years, we're growing market share by promoting off-label all the time. I mean, all the time.
Amazing. So you've stood in the room with physicians, you've pitched to them, you've sold to them, years before we ever, come into a COVID moment where I think people started seeing things differently. But, after that experience, did it change how you would describe the mentality of a doctor?
Oh, 100%. I think doctors, whether doctors, surgeons, any of these clinicians, they go to med school with the best of intentions. I really do think most of those folks really do care, and they start out passionate and wanting to bring meaningful change and help people. And then by the time they get into private practice, they are so chewed up, spit out, beaten down, abused, and exhausted that they've surrendered to the system. And so in medicine, we say, we can't treat the disease without uncovering the root cause. A clinician is in a position where they're so siloed now in America, they don't have a holistic view of you as a patient. So if I'm a primary care and I have 6 minutes with you on average in this country, which is what they have, to go over family history, do any sort of comprehensive analysis of where you stand. The entire system is built to get you in and out of there. And in a way, it creates plausible deniability for the clinician because they're going to say, well, I wasn't able to do the test because insurance wouldn't let me do the test. Or I wasn't able to do a deep dive because insurance won't let me do a deep dive. So what does it do? It drives behaviors and habits. I'm getting commercials from drug reps telling me to prescribe drugs. I'm using the tools in my tool belt, and my tools are limited because the insurance companies encourage me to prescribe prescription medicines, but discourage me from doing a deep dive preventative care, comprehensive blood work, comprehensive genetic tests, gut biome tests, anything predictive, personalized, or preventative, the insurance obstructs. Anything prescription driven that gets you in and out of the clinic, the insurance companies approve and push. And I can methodically explain why. And so you look at it and you
go,
why?
I mean, I think people would think all those drugs end up costing like billions, if not trillions of dollars. Isn't the point of an insurance company to make their overhead lower, or are we missing something?
No, this is the dirty secret. So as HMOs and these insurance plans blew up, the insurance conglomerates took more control over our healthcare system. So many people don't know this. The 5 insurance companies are literally 4 times the revenue of Big Pharma.
Really?
I'm going to say it again so you're listening. The 5 big insurance companies are 4x the revenue of Big Pharma, over in the trillions of dollars. Like, they're juggernauts. And those insurance companies decide what treatments you get, when you get treatment, whether you get to go to a primary care or you get to go to a specialist. They control the flow of patient lives, the prescription drug care in America. And so these insurance companies blew up, became these huge juggernaut entities. In the 80s, prescription drug care was going through the roof. And the government said, we've got to do something about this. So the vision was to establish what's called, they're now known as the middlemen that Trump keep talking about, the pharmacy benefit managers. And these PBMs were there to be an advocate for the American consumer, to negotiate with Big Pharma, to drive down the cost of our prescription drug care, making medications affordable for me, for you, for our grandparents, for Medicare, for Medicaid. At some point, the insurance companies thought, aha, this is another potential revenue stream. Let's go buy the pharmacy benefit managers. So all of the big pharmacy benefit managers in America are owned by the big 5 insurance companies. There is no separation.
Really?
So the company that was supposed to be negotiating on behalf of the people are now owned by the insurance companies that are negotiating on behalf of their pocketbooks and their quarterly earnings. And here's why that's important. As soon as they acquired the pharmacy benefit managers, you see a skyrocket in the cost of prescription drug care. You also see the average American increase the amount of prescription drugs they're on. The average American right now is on 4 or more prescription drugs. And so to answer your question earlier, if I'm an insurance company, wouldn't I want to prevent people from being on prescription drugs? Because doesn't that run up the cost of my plans?
Yeah.
And the answer is yes. It does run up the cost of the plans, but the insurance companies never pay the price because it's a shell game. And I'm going to show you how the magic trick's done. So one of the ways I always explain it is the margins are made in the mystery, right? People say healthcare is so confusing. I don't understand what am I getting for what I'm paying for? That is by design.
Yeah.
It's not broken. It's rigged. And we're fitting the bill financially and in our health and our family's health. And so an example would be insulin. Eli Lilly, when I was there 20-something years ago, was literally selling insulin for, I think, $135 a vial. I think most recently, the Senate Finance Committee did an investigation into insulin to try and uncover why it's so expensive, over $380 a vial in the United States now. Why? It's because the insurance companies use their middlemen holding company, the PBM, to negotiate up the price of a drug. So they go to Big Pharma, and before they say, you've got to cut your price. We'll put it on formulary, but you've got to cut your price. If you cut your price, we'll give you tier 1 placement, meaning you'll be the biggest blockbuster drug in the world. That's not what they do now. What they've done for the last 20 years is go to Big Pharma and go, if you want to be on tier 1, you're going to mark up your price. So for simple math, let's just say insulin was $200 a vial. They'll negotiate for insulin to be $400 a vial. They'll hold a $200 rebate at the PBM. So $400 a vial, they get billed the $400. United Healthcare shows they paid $400 to me, to you, to your employer, because 90% of Americans are insured through their employer.
Mm-hmm.
Okay, but they never paid $400. They paid $200 because they got a $200 kickback to their pharmacy benefit manager holding company. That's a crucial piece of the puzzle to understand. United Healthcare did $365 billion last year in revenue. 60% of their revenue came from the PBM.
Wow.
It's just a holding company to hide their profitability. Now, United will show your employer at the end of the year, because like I said, 90% of Americans are insured by their employer.
Yeah.
So like I employ 270 something people.
Yeah.
United comes to me at the end of every year and says, Brigham, we spent $2,000 a month on Joe Bob, because he's on metformin and GLP-1 weight loss drugs. We've got to raise your copays, your premiums, your deductibles, and your out-of-pocket expenses. But they never spent that money. They spent a fraction of that money. So do you get where I'm going with this?
Yeah.
And they do that on every drug throughout the entire system. And those are the blockbuster drugs. And they decide the tier placement of the drug to steer consumer behavior based off which drugs they're getting the biggest kickbacks on.
Just a marketing advertising arm then for the drug company. And they charge you a premium to push your drug forward, and they get this giant kickback basically.
Boom.
From it.
And then they pass that cost on to the employer. And then if we look at Doge and we look at governmental payers, what a lot of people don't realize, you and I were talking about Medicare right before we started this. Medicare, Medicaid, TRICARE are an illusion. They are not governmental payer programs. They have all been outsourced to who? The big five insurance companies. Yeah. And then how do the big five insurance companies show the federal government that they're trustworthy? They tell the federal government the average wholesale price of insulin in America is $400 federal government, but we're giving it to you for 20% cheaper, wink, wink, nod, nod. But it was never $400, right? They set the wholesale price, they set the market price, they set the reimbursement rate, and then they fudge the numbers. We're all paying the bill. And then where it gets even dirtier, and you can stop me at any time. But
I'm fascinated by it.
So I asked a bunch of senators this at a dinner last week here in Texas because they're trying to understand prescription drug care and why the drugs are so expensive. Between 2010 and 2019, there were 360-something blockbuster drugs. 360-something blockbuster drugs.
What does blockbuster mean? Like, how do you define
Meaning
that?
like hundreds and hundreds of millions of dollars is how they're defining these drugs. Like big ticket drugs that are considered blockbuster to society. Out of those drugs, how many do you think Big Pharma created, innovated, and brought to market?
I mean, assuming all of them.
The answer's not a fucking one.
Really?
Zero. Zip, zilch, not one drug. 100% of those drugs came from the NIH, which comes from what? Taxpayer dollars.
Really?
We are innovating drugs. We are financing drug innovation. Us, the American people, the taxpayer. Then those drugs are sold off for royalty rights and basically minute incentives to the NIH, where they're then brought into the FDA via the Big Pharma pathway and brought into a marketplace. And then we're told by Big Pharma, we've got to charge these exorbitant rates because we're responsible for innovating for the world. Bullshit.
We already paid for the
We already
innovation.
paid for the drug. And then one
So
example.
we're socializing the cost of developing the drugs, and then they're capitalizing the profits on the other side.
You got it. And then not only do they mark up the price to get their Big Pharma market, then they turn around and the big insurance company says, well, we've got to get our cut. Right? So we're quadruple paying for a drug, and they say we're innovating for the world, but we're really innovating for the pocketbooks of Big Pharma and big insurance. And that is why big insurance is incentivized for you to be on prescription drugs. A huge chunk of their revenue comes from monetizing chronic disease and prescription drug care. And so if I'm an executive at Blue Cross Blue Shield and I see, again, I'll use Joe Bob here in Texas as an example.
Yeah.
He's pre-diabetic. He's on the cusp of metabolic disease. I know if this guy transitions to diabetes, it's a 7 to 8-fold increase in my cost to keep this guy alive for the rest of his life. Why would I let him make that transition? Because I'm monetizing the chronic disease.
Mm-hmm.
If Joe Bob goes on insulin, cha-ching. If Joe Bob's on cha-ching. Every single one of these compounds is a revenue generator for me and my board members and, all of my investors.
Amazing.
And so that's why we're on so many prescription drugs, and that's why chronic disease is at an all-time high. We're the sickest country in the world. 1.7 million people die a year in the United States of chronic disease. More than every war we've ever fought. We're so focused on war and what's going on. And I'm not here to trivialize war. It's terrible. It's terrifying.
No, you're right.
But it's equally terrifying that we are dying silently in this country to capitalism. I mean, candidly, to like egregious levels of corruption and corporate capture of our institutions.
I've been seeing all these videos just this last week. Actually, been paying attention to people saying the hospital accidentally gave me the forecast price. I was like, great, I'll take it. But then my insurance company stepped in and said, no, he's got insurance or she's got insurance. All of a sudden, the bill went through the roof, like $4,000 or $5,000.
Yeah.
And after the copay, they're still paying like $1,800 versus the $600 cash price they could have paid. Like, can I just go back and pay the cash price? Like, no, sorry, you have insurance.
Yes.
So you personally are paying more. I mean,
and I've witnessed all
I
that.
can't believe that police officers aren't just coming in as soon as you see that saying, whoa, hold on a second. This is like people are being robbed.
Yes. So they do so many things that they monetize the prescription drugs. That's one aspect. There's what's called gap pricing. So I only know this. So walking through my history, I worked as a drug rep. I worked as a surgical device rep with some of the best and brightest surgeons in the country, which is a whole nother racket. So I saw the whole surgical system, copays, deductibles. Another way that they obstruct care is they put huge out-of-pocket copays on surgeries, right? Usually $10,000. So if I'm a young 25-year-old kid and I've got a neck or back injury, they're going to push me to an opioid or a prescription drug that they're monetizing. They're going to make me fail on that prescription drug for probably a year before they'll ever approve an MRI or a surgery. And then they're going to have a huge out-of-pocket expense on the MRI or the surgery to discourage me from having the MRI or surgery.
Right.
Because they're not revenue generators for
They want you
the
on
system.
drugs.
Correct.
Wow.
So they intentionally make the price high to discourage the patient from seeking that treatment. That's by design. And so and so many people don't understand. So like when I owned a retail pharmacy here in Texas, at the time, we had a gag clause. I was not allowed to disclose to your, family member if they were to come in and they say, I have Blue Cross Blue Shield. I swipe their card. Metformin was a drug that's been on the market 30 years by now. And it was like $2 a month was my cost. I would sell it to you for $4 a month cash price. As soon as I swipe your insurance card, I'm not allowed to tell you your cash price. I had to tell you your copay. Your copay was $10.
Wow.
I don't get to keep that extra $6. I don't even get the $4. The insurance company would claw back $7, funnel it to their pharmacy benefit manager where they made $7 off a drug that should have cost you $4 that I would have made $2 on, but instead I made $1. And so they ramrod the pharmacies nationwide to make it hard for them to survive. And then they profiteer off of every single drug that touch, even generics. And then separate from that, they try to force you to go to their own mail order pharmacies where they're monetizing it even more because they've negotiated lower and lower rates because they're controlling the volume more and more.
Well, so when you look at like telemedicine is coming into play, like is that driving costs down? Is that there for the consumer? I mean, I just saw this, during the Super Bowl they had was the him/her ad or something, and it sounded like it was like really MAHA, like, oh, get healthy. It's showing vegetables and stuff, and then in the end, it's just selling me more drugs. And I just thought, this is just another drug sales commercial. They're just acting like, oh, the big bad pharmaceutical company. You know what the secret is? Buy those drugs through us.
Yeah.
Is it? Yeah. But does it benefit patients?
So I own a company called Ways to Well, and our goal is to get proactive, predictive, and personalized. And so my message that I've been saying for years is we can't treat what we don't see, and we can't prevent what we don't look at. If we really, truly want to prevent chronic disease in this country, it starts with taking a look under the hood. And it starts with comprehensive blood work, comprehensive analysis, genetic testing, gut biome testing, all these amazing tools in the tool belt that are out there, but that are being suppressed by the insurance companies because they don't want to pay for it.
Right.
They want you on prescription drugs. I fundamentally disagree with that ad. It's funny because the next day I was doing calls with Callie Means and a bunch of the MAHA folks. And, because I own compounding pharmacies as well, where we compound medications now for pennies on the dollar, mailed to your doorstep, cheaper. Like a GLP-1 is $1,500 in the insurance model.
Yeah.
We do it for $250 mailed to your house.
Wow.
Why is it $1,500 a month? Because of all the things I just told you. Everybody is marketing up and taking their little cut throughout the system. That being said, does that fix the problem of humanity? Because human nature is we all have a greed gland. And candidly, even in telemedicine, it's moved to a cash pay where they do have the autonomy and the sovereignty to do what's right for the patient. But it's going to be a constant battle between what pays the most money, makes the telemedicine company the most profits, and what is best for the patient. And so it's not good or bad. The issue isn't necessarily the archer or the arrow, it's the archer. Can we run telemedicine, save money, take cost out of the system, and drive health span? Absolutely. And that's like what our mission is at my company, is to help drive health span, prevent chronic disease by never letting it develop in the first place. However, what I've seen in telemedicine, unfortunately, is a lot of them have gone to a phase where they're just essentially pill centers that are trying to crank out as many prescription drugs as possible and monetize those prescription drugs via a cash pay solution.
So that's the drug side of it. Everyone's getting in the drug side, but I'm curious where you're saying that the insurance company is blocking or making it more expensive to get into the surgery space.
Yes.
Now I did, when I was a producer on the daytime talks to the doctors, like I was scrubbing in, I've shot hundreds and hundreds of surgeries. I've watched miracle workers, and I've watched guys that shouldn't have been a car mechanic. And I remember thinking that, when people would say, well, what did you learn, working at the doctors? I was like, man, you would be shocked how bad some of the surgeons are that you're going in. I mean, I would be there, you're out cold, and I've watched pieces of skin get dropped on the ground, picked up, brushed off, just crazy stuff. And shockingly, it was sort of the best doctors were the ones that were the most sort of under review, the ones that were really, truly like doing things that I just thought were spectacular and saving lives. There was sort of the hacks that seemed to control the industry, but that was my own trip. But, in surgeries, what's happening do surgeons make money? Do they know that they're being blocked from getting these clients coming in? Do they know that they're in some sort of internal battle with the insurance company?
So what's happened is the big hospital institutions, for the most part, have gone out and gobbled up primary care practices. So there's not a lot of independent primary cares left in this country because they just can't make a living in the insurance model. And so those folks have essentially just become little drone worker bees. There's a mass exodus. It's not to their own doing. Most primary cares are unbelievably frustrated. They feel like they can't do deep dives into their patients. They can't prevent chronic disease because they can't get approval for any of the tests to actually look under the hood and treat the patient. So I tell people, think of your insurance, your health insurance, like car insurance. It's there if you total the car.
Yeah.
It is not there to change the oil, rotate the tires, maintain the car. It's going to wait for you to total the car, and then it's going to monetize that. Clinicians have a challenge getting you approved for surgeries because insurance companies have created an obstructionist mindset to those approvals. So like Luigi, the kid who shot the United Healthcare CEO, like terrible event, like tragic what happened, not condoning what happened in any way, shape, or form. But his frustration was representative of so many other Americans' frustration level. You spend all your hard-earned check paying these insurance companies for the day that you're going to need care, and then unless it's a prescription drug, they make it really hard for you to get the care that you paid for.
Yeah.
And what do I mean by that? One way they do it is through an egregious level of copay or deductible, essentially making the hospital, the MRI center, or the comprehensive lab test center, whatever, maybe if you're doing an in-depth genetic test to try and uncover what's going on with you physiologically with some sort of chronic issue, they put huge copays on that. Oftentimes $2,000, $3,000, $5,000, $10,000 on most surgeries. And what that does is it makes the hospital or lab a subprime mortgagee, right? You're a subprime mortgage lender to these people because the way the contract reads, and this is where this gets really dirty and nuanced, I'll do my best to simplify it. I want to open a hospital. I go to the big 5 insurance companies because they control 90% of the revenue in this country.
Mm-hmm.
I say I want to be in network. One, they're probably going to tell me to go pound sand. If they do that, I now have to bill them out of network because they won't give me a contract. And so what does that mean? It means I have to create a bill master and hope that they pay me for the surgery. And so you usually inflate your costs by 3x, which sounds crazy, but it's because the analytics will tell you they're only going to pay you a third of what you bill them.
Wow.
So now you're forced to bill them 3 times to get paid what you should have been getting paid in the first place. That's if you're out of network. Let's take the more nuanced, say if you're in network and you get the contract and now you're good to go. You got an in-network contract with pre-negotiated reimbursements. Takes 60 to 90 days to get paid. The insurance companies are going to short pay you. The insurance companies are also going to say, did you collect your copays and deductibles from the patient? Well, the patient was on the hook for $10,000. And the way the contract reads is you have to make a reasonable effort to go after the patient for the money. So this is why healthcare is the number one reason for bankruptcy in America, because the hospital doesn't want to be harassing and chasing down a patient for the $10,000 copay. But the way the contract reads, they have to. And both the hospital and the insurance companies know only a small fraction of those copays ever actually get paid.
Really?
Yes. Most people negotiate them down and pay like 20 to 30% of the copay. Here's why that's a problem. It's a lie agreed upon. Because now let's say you're 3 years in of billing United Healthcare. Let's say United Healthcare owes you $50 million for the quarter. And United comes to you, Methodist Hospital, and says, yeah, fuck you, we're not going to pay you the $50 million, which happens a lot.
Mm-hmm.
And they go, we'll give you 30. We'll settle at 30. Your attorneys are going to say, if we fight them, we could potentially lose the lawsuit because you only collected 20% of your copays. Do you get where I'm saying?
Yeah.
So they've built a system to be able to pull a lever and intimidate
they get you to cheat
and bully.
They just sort of basically force you to cheat it or lie or steal in a way. And they look the other way until you ask to get, the money back. And they go, well,
correct. And
we get,
and the verbiage in the contract's vague. It says you have to make a reasonable effort to collect. Well, what does that mean? Does it mean you send a bill in the mail? Does it mean you call them and report them to collections? Does it mean you call them 18 times? Does it mean you file a complaint? But you're leaving the hospital having to chase down the patient. And this is why they inflate the cost. They inflate the cost on purpose to intimidate the patient away from wanting to get the treatment. And that's why patients go...
And everybody's in on the hospital's in on it because they know they're going to have to chase you for a copay and the greater percentage are running from it. So we don't want the surgery either.
You got it.
What a trip.
And so you were asking about... you were asking earlier about telemedicine. So here's why I started my company, Ways to Well. I was in the space of owning blood labs. And I went to the insurance companies and said, I would like to be a network. Guess what? They said, no, go pound sand. Okay. So now I have to bill them $900 to get paid $300, right? That's just how it works.
Mm-hmm.
Okay. And then because I billed the $900, if they don't pay it, the way they word it is I have to go after the patient for the $900. But I didn't want to bill $900.
Right.
I just wanted to get paid the fair rate you're paying everybody else.
Right.
But now you've built a model where
and
I
now
have
I'm coming up short on delivering on
Got it. Contractually, and now I've exposed myself to where you can hammer me in litigation, and that is how they've built the model. And that's how they're controlling, bullying, and intimidating hospitals, surgery centers, MRI centers, you name it. They're terrified. And it goes even deeper. So I build a blood lab. I spend all my life savings to build this blood lab. I go out and I market to clinicians throughout the United States. I educate them on the importance of getting proactive and predictive. This was before I knew how dirty it was. We're doing great. Doctors are like, you're right. If we could do comprehensive blood work, we can prevent chronic disease. This is a brilliant plan. Let's get proactive and predictive. We grow this blood lab, and within 6 months of it getting legs and being a big lab here in Texas, all the doctors start getting letters from the insurance companies. We do not want you pulling comprehensive blood work. If you continue to look at all your patients with comprehensive blood work, we will revoke your contract.
Wow.
So not only do they intimidate the labs, intimidate the pharmacies, intimidate the hospitals, they intimidate directly your primary care and internal medicine doctors. And if you lose an insurer in the state of Texas, one insurer as a primary care, you're out of business because you can't make payroll. You've got to have the big 5 insurance companies because they control the patient lives and the flow, because 90% of people access their health care through their employer, which is through these insurance companies. And so they're terrified of the insurance companies. And so when you asked earlier, what about the doctors? It's not that they have bad intentions. They want to help, but they're castrated. They're terrified.
Worse than that,
they're bullied
they're
and
basically
intimidated.
chained, tortured, hogtied.
You got it.
They're, to do anything to try and help. They're putting their career at risk. Their hospital's pissed because it's costing them money and copays that they're not going to get.
And
So
they'll
if you
try
get
to
out-
say, like, so our blood test that we do now would be $2,800. I had a UFC fighter mess up and go in and give his insurance card. They were going to bill his insurance $2,800 for the blood test that we do with an hour consult with a doctor for literally, I think it's $480, and that's with your hour consult. And so why is it $2,800? It's not because your doctor or the lab are egregious. It's because the insurance company has built this system to delay, deny, and depose, like to scare and bully you out of treatment and out of having accessibility to true healthcare.
It seems to me insurance now, the way you're describing it, is essentially like I am putting a drug dealer, or even worse, probably a drug cartel, on retainer.
You nailed it.
I'm giving you money every year. When I finally have a problem, maybe I need a surgery, you're going to bully me and say, you can't afford to do that surgery, but we got drugs for you. 1, 2, you have side effects, 3 and 4 and 5 drugs, and we're off to the races. And anyone tries to mess with us, we'll talk about pulling their
Boom.
contract with us.
You nailed it. And,
Wow.
and another example I can give you, and this article came out, 30% of the revenue generated from the opioid crisis went to the PBMs. They were, and what's insane is I lost my brother to the opioid crisis. And
sorry.
It's what started my whole mission with this. I was literally in the middle of building my first compounding pharmacy, where we were pitching and educating clinicians on the importance of not writing opioids. And my message was, and I used, one of the head of Obama's healthcare for opioid crisis folks to help me design our plan. And it was, look, don't write an opioid. There's alternatives. There's non-abusive, non-addictive topicals that literally for, a couple $100 a month, you can avoid that patient having a endocrine disrupting wreckage system, addictive compound in their system. Instead, write this topical. If you insist on writing an opioid, there are checks and balances. 1, a genetic test. A simple cheek swab can tell me if you're a slow, fast, or moderate metabolizer, help me avoid you ODing, give me a genetic blueprint to let me know if you're at propensity to become addicted or die, and then a toxicology screen. We should test. And these are the government's own protocols. Here's the problem. Guess what happened? The big 5 insurance companies within 6 months during the opioid crisis said, fuck you, we're not covering toxicology screens. So now you have no way to see if this patient's diverting the medicine or even taking the medicine. We're not going to cover pharmacogenetic tests. So now you have no way to assess this patient at a cytochrome P450 genetic marker level, which would give us the blueprint to be able to avoid addiction and chaotic destruction.
Yeah.
So those 2 options are gone. Now the last leg was prescribe them not an opioid, instead prescribe them a non-abusive, non-addictive topical for orthopedic injuries, knees, shoulders, elbows. A lot of the people who got addicted to opioids, we could have avoided that crisis. All of those pillars were ripped out from under the American people. Why? Because the insurance companies were monetizing your opioids. They were making buku dollars off you being on opioids.
And addicted. And the more you purchase and the deeper you go, the more they keep cashing in.
You got it. They didn't want us not on. And that is the system we live in. So when we look at it and go, why is there a rise in chronic disease? Why are deaths of despair, depression, anxiety at all-time highs? Diabetes, all-time high. Metabolic disease, all-time high. Cancer rates, all-time high. Follow the money. Show me, my dad always said, show me the incentives and I'll show you the outcomes. We've built a system that monetizes and perpetuates chronic disease and trades healthcare outcomes for quarterly profits. And then we go, wow, look at these amazing quarterly earnings and profits and our terrible healthcare outcomes. Well, we built the system. We should know and now know what to expect with this system.
How would you fix it? Obviously, you've stared at this. You've stared at the eyes of the dragon. How do you defeat it? Because it seems almost insurmountable. It seems like they've got their tentacles in every single part of this. They've got the hospitals. They've got the, third-party payers. They've got the government. Everyone seems to be, they've got NIH doing all of their research. I mean, the whole thing. And you're saying we're all screaming pharma, but insurance, you think, is really, the insurers are the biggest.
It's all of them. It's big pharma, it's big insurance, it's big industry, it's the corporate capture of our institutions, it's the cross-pollination of whether we talk about the NIH, the FDA, or HHS. There is so much spit being swapped with our high-level leaders in governmental organizations that 1 month go work and regulate an industry and then 2 months later go work for the very industry they were regulating. It's not just the FDA. So many people talk about, I think it's now 10 out of the last 11 heads of the FDA have gone to work for industry, including, the head of the FDA that helped the Sacklers launch opioids into the market. But what people don't talk about is a multitude of the head of the HHS and our Medicare programs have gone to work for the PBMs and negotiated the deals with Obamacare, that whoever was the head of the program at the time for Obamacare went to go work for the pharmacy benefit manager lobby groups. After she left her tenure, I can't remember her name, I'm blanking out, inked the deal. 6 months later, goes to work for the very folks that she was inking the deal with and supposed to be negotiating against. That level of corruption and collusion has to stop. So one thing would be, can we stop these governmental officials from jumping back and forth, or at least put some sort of time frame? You're not allowed to go work for industry for 24 months, something to start protecting, the American taxpayer, the American people, and our health. That would be one. Not allow big pharma to advertise directly to consumers. That would be a great one.
Huge, yeah.
And then Callie and I have talked in depth about this, increasing HSAs, giving people tax incentives to get proactive, predictive, and preventative. Because even if we allow the insurance to start getting proactive or force them to, I just can't help but feel they'll find another loophole to screw us and screw the American people.
Yeah.
So I look at it as giving sovereignty to the average American. So many people go, man, I would do a blood test if my insurance would cover it. But they're looking, for the insurance companies to solve their problem. And I understand why, because they go, well, I've been paying these guys. They should cover my blood test. I think they should too, but unfortunately they're not going to.
And does the government have any authority there to come in and say you have to, we are tired of, even if it comes down to drug interactions, we want you testing what drugs they're taking, the drug interactions, levels that are in their blood, how much are they taking, and things that you're talking about. Can't the government come in and or does that seem authoritarian to some people?
I don't know. That's where it gets tricky. But to me, I look at it and go, what if we had an HSA account where you could put away $20,000 a year tax-free, and that's your health plan to cover preventative care. And you can decide, do I use that for massage? Do I use that for a gym membership? Do I use that for comprehensive blood analysis twice a year to deep dive to make sure I'm not headed towards a chronic disease? Because what we're doing at Ways to Well is we're using algorithm-based medicines and large language models to assess blood work and drive down the risk profile of chronic disease. And so we'll quantify for you, here's your linear age, here's your biological age, here are the 5 chronic diseases that are killing so many people, here is your percentage of chance of developing those chronic diseases. And can we prevent that? The challenge to that is insurance is not going to allow that, right? Insurance doesn't cover that comprehensive blood work, 1. But then 2, the caveat I would get is, do you want the insurance companies digging through your underwear drawer? I don't know if I want those people having that health data, because if they can quantify when I'm going to head to a chronic disease, they're going to use that to cut my program or eliminate me before I have that chronic.
Maybe like Minority Report for insurance, suddenly I'm paying more for the disease that's out there in my future.
That's what's terrifying.
Wow.
And so every solution creates another problem. And that's where I go to, this patient, we've got to empower, embolden, and create an environment where patients have control over their health and their healthcare data, separate from the insurance companies.
Yeah.
And that means we've got to give them a solution that doesn't entangle them with the insurance companies. And so the only solution I can think of is improving HSAs, giving tax incentives to individuals to get proactive, right? Maybe it's a big tax rebate if you fund an HSA. Incentivize people to get proactive and predictive and take themselves out of the broken system and not let BlackRock, Vanguard, State Street monetize death and despair. Like, that's
my concern, because when having worked with Bobby and looking at how do we with MAHA make America healthy again, how do we do that without being elitist? Because a lot of the things you're talking about, right, whether it's a concierge doctor that's pulling himself out of the system saying, I'm out of the insurance system, I don't want to be controlled by it, I can only treat your health and actually do the diagnostic studies if I've separated myself from that, being on that tit, if you will, and now I'm on my own. But that's a cost that a lot of people, for if you don't, you have to have decent income to be paying for a concierge doctor, or going, or even using, what you're talking about. It's outside of my insurance system, right? I want to get proactive. I mean, do you think we just have to make that work first? Like, okay, fine, the middle class and probably upper middle class and rich will be able to do this, but if we can create enough supply and demand, maybe we can drive the cost down. I mean, how do we get there? How do we get there? We're actually caring about the entire country and not just those of us watching, MAHA that are buying organic food and can afford it. It just feels like health right now is a totally elitist space.
No, I agree 100%. That's the challenge. And that's the conundrum I face every day, trying to create a cash pay model that's affordable to the average American. And there's brilliant doctors out there, like Peter Attia and a lot of these preventative longevity doctors, but nobody can afford those guys. Very few of the elite of society can afford those individuals. I think large language models, algorithm-based medicine, volume, driving down the cost of lab work and accessibility to getting proactive, predictive, and preventative. And that's what I'm attempting to do at Ways to Well. But yeah, even for us, it's still a couple $100s a month. And for a lot of Americans, they can't afford that. My devil's advocate to that is, what do you spend a month on beer? What do you spend a month on margarita? What do you spend on your mattress, your car payment, your house? Those are temporary things. 400 trillion to 1 are the chances we're alive right now in these bodies. What are we going to do with it? This is all we've got. This is our one shot at living a healthy, happy life. We've got to make it affordable for people. We've got to make it approachable. It can't be intimidating, and it has to come from a place of support and education. Because my other challenge with the system is it's very dictatorial. Like they're very authoritarian. I stand on this pulpit and I tell you what to do. That's not empowering patients. No. You've got to educate the patient and explain the why. And and that's my issue with the weight loss drugs. Like the GLP-1s, you got one side saying they're the greatest innovation ever. You got the other side saying they're the devil. And the truth is always in the middle.
Right.
It's a tool in the tool belt when utilized appropriately to treat morbidly obese, diabetic, metabolic disease-ridden individuals. It can be life-saving.
Yeah.
It probably shouldn't be being prescribed for the girl trying to lose 10 pounds for spring break.
Right.
Right? It's overutilized. But my point of saying all that is, if we had a system that took the time to educate and talk to the patient about diet, lifestyle, nutrition, if we had clinicians actually educated in medical school on nutrition, which they take no nutrition courses, they don't know anything about diet, lifestyle, or nutrition for the most part, and they're not incentivized to do so. So what reward systems can we build for the average American? And that's where I go back to, if we gave a big tax rebate to hitting certain health parameters, incentivized Americans to be healthy, and then gave them an HSA plan to give them accessibility to these type of tests, you're not talking about an insane amount. Even one biological comprehensive blood work a year and a 45-minute call with a clinician.
Set you on a better course. At least you're not in the dark completely.
You got it. And that would be like $50 a month.
Yeah.
Anything's better than what we're doing, which is nothing.
Right,
we're doing nothing.
You keep saying, you're bringing in large language models, AI, it's funny because I think we're sort of in this natural health movement. People are like, oh my God, AI, I think in about a year, everyone's going to realize it's sort of like saying, oh my God, the internet, I'm not going near it. It's everywhere. I think there's some safety in that. I mean, I'm one of those people. I've reported a lot. I'm terrified of AI, but it's looking less like there's like one giant AI that's going to control the world, and it's just going to be a billion AIs with every idiot with a company, and my AI might just be a battle of a billion AIs. Like, I'm not sure, messy, but I'm not sure how dangerous that is. I mean, I don't know.
Yeah.
But the point I want to get to is, first of all, what's it doing in medicine from your perspective? I think it's going to be catastrophic to the doctors, all of those doctors that have, as you pointed out, have been really reduced to just being the drug delivery guy.
Yes.
You got your 6-minute, counseling session, and already there's bills as soon as this election year started, there's bills in Washington D.C. to, just say AI can prescribe drugs. I think it would probably be perfectly fine. It'd probably be better. I mean, of all the things I think AI can do, I think it'd probably do that fine. If you want to, all a doctor is Dr. Google now. I mean, they really aren't getting your family history. They don't know anything about me. They don't care. They're just going to go and say, well, CDC or whoever says take this drug, or this drug rep just came in. Why do I need that doctor? To me, the doctors have reduced, and maybe not their fault, because you've pointed out, you've given me a little more empathy for the situation than I normally have, because okay, I see that they're being controlled by everyone around them. They're just pawns in this, but those pawns literally are just pawns now. Like, they can be removed without any loss to the system. I have to imagine the next 2-3 years, you're going to lay off so many doctors, because AI will just say, I can look at your drug profile and figure out what your side effect is. You just type it in or speak to me. I'm having this reaction. Oh, great. And let's take you off that. We'll put you on these other two. AI is going to be really good at that.
100%.
Right?
So the beauty is, so let's go back to even my company. How do I grow, scale, and make it affordable? Right? And these are the challenges I face every day as an entrepreneur. We have 67,000 plus patient lives, last I checked, at Ways to Well, mainly probably because of Rogan and Tucker and these podcasts. Yeah. But the way we practice medicine, I have to pay a clinician to see 6 patients a day. In my model, that's all they can see. Okay, well, how do I drive down the cost when I've got to pay a human capital resource an exorbitant dollar amount, and they can only see 6 people a day? And then I still got to pay for your blood work. The answer is large language models.
Yeah.
We've launched a large language model that can assess your blood work, review your DEXA scan, which is a full body assessment that tells us how much bone mineral density you have, how much lean muscle mass you have, how much visceral fat you have. Combine that with tie into your wearables. Now I know your heart rate variability, your REM sleep, your deep sleep, and your VO2 max.
Mm-hmm.
You give me comprehensive blood work, a DEXA scan, and a VO2 max with over a 90-something% accuracy rate. The large language model can now begin to model out your risk profile of developing a chronic disease, list out how we can intervene and prevent that chronic disease, assess the blood work, assess the DEXA. These are all things I had to pay human capital to do before.
Yeah.
Right? And I could only see 6 people a day paying my clinicians. Imagine a world where I could spread that clinician out to see 100 people a day. It's not that the doctor would go away, it's that their bandwidth and their patient care would improve, because a lot of the heavy lifting is done by the large language models. And now I put training wheels, not to be derogatory, but I put guardrails on a new clinician who's maybe right out of med school. Because that clinician, it takes years of being in practice to learn the nuances of preventative care, predictive medicine, like functional medicine, diet, lifestyle, nutrition. My large language model does all that instantly. So the example would be, I have your VO2 max, your DEXA, all that. We know that you have 180 pounds of lean muscle mass. We know that you're carrying around 40 pounds of body fat. We know that your BMI is unhealthy. The large language model is going to come up with a plan to get the fat off and protect the lean muscle mass. It'll be able to be a nutritionist, to give you a meal plan, to spell out a recipe for you, to help you create a grocery store list, all of that instantaneously. It knows when you started prescription medicine, what date, and then it's tracking your trends from the date you started an intervention.
Yeah.
So a lot of what we do is more like proactive predictive medicine, like peptides or hormone optimization. A lot of the stuff they're just not doing in a primary care space, right? If I know that you were to start testosterone optimization on the 15th of this month,
every
every 15 days, that large language model is proactively reviewing everything every day. We're tracking, did your REM sleep improve? Did your deep sleep improve? Did your heart rate variability improve?
Yeah.
Or did it decline?
Yeah.
And if it declined, we need to make another medical intervention and adapt. The model we're in today is you show up to a clinic, I take a shot in the dark, I prescribe you a drug. I don't even know if that drug's going to work. I don't know if you have a methylfolate detox issue. I don't know if you have a gut biome issue. I don't know if you have a cytochrome P450 issue. I don't know if you're a slow, fast, or moderate metabolizer. I'm just literally throwing darts at a problem with no deep dive or analysis. And that's what the system's built to do.
Mm-hmm.
We can squeeze the cost out of healthcare. And we can absolutely drastically, imagine if we just cut out the PBMs. There's 30% of the spend gone. Imagine if governmental payer programs are run by somebody who actually understood what's going on. There's another big chunk of revenue gone of waste and fraud and abuse. We can fix all these things. And what large language models are really good at doing is taking a plethora of data, a massive amount of data, and streamlining it into data sets that we can act upon. And so imagine when Ways to Well has 3 million patients across the United States, what kind of trends we'll be able to extrapolate and how we'll be able to improve and refine predictive medicine. And even with cancer screenings, like today, we can do a cancer screening that can test at stage 0, literally stage 0, up to 7 years in advance. Why is that not being utilized for our first responders and our military personnel? The answer is insurance doesn't want to cover it. Why? Well, because 70% of an oncologist's income comes from chemotherapy.
Mm-hmm.
Like every freaking rock you look under in healthcare is another damn rattlesnake. And it's by design.
Yeah. They don't want you. They don't want you thinking about it until you need them. Like, don't go anywhere. Don't think about it. Live your life. Eat whatever you want. Drink what you want. I'm waiting for you. You've been paying for the drug pusher to be here. We're waiting.
And then the real cost of care comes after the age of 65.
Right.
And now you're the federal government's problem. So now any of those surgeries or any of that are covered by the federal government, not by the insurance plans. And the insurance plans are still getting your medications and monetizing your chronic disease because they control the governmental insurance plans
pass off
for the
most
drugs.
Expensive part to the government, to the taxpayer.
You got it.
Wow.
It's a racket.
Genius.
Yeah.
Got to hand it to them.
Yeah.
How are people adapting to, are people reticent about like having AI looking at their data? I mean, do you have any pushback, or can you tell, are average people going to say, hey, I'm cool, like interacting with a robot basically on my health issues? Is there a learning curve that is going to be taking place or has to happen, or are people just, I'm in? I mean, I don't know.
I think it's a mixture, I'm 44. I think people my age and younger are pretty open to it because we grew up in a more technological world.
Mm-hmm.
I do think regardless, it is the future.
Yeah.
Like you said earlier, I truly think that the existing healthcare system is a dinosaur and large language models are the meteorite. Like it's coming whether people want it to come or not, because the system's so fundamentally broke, and it's a sword that cuts both ways. Like, I'm not here to tell you it's all good or all bad. The same thing I say with GLP-1s. We have to be cognizant of the pitfalls.
Mm-hmm.
I would be very wary to put this in the hands of the big 5 insurance companies. And that's where I think we have to build a life raft through HSAs or some sort of alternative plan that allows patients to control their preventative care. And like, you don't really want the insurance companies having quarterly blood work analysis on you, because they'll be able to model out and predict where you're headed, like we were saying earlier. But you as a patient have tremendous benefit. Knowledge is power. And so the example I can give is like, my dad who's, been diabetic and obese his whole life. I can literally use a large language model to break down for him daily. Like, Dad, hey, we can help you get this extra 40 pounds off.
You still has to do the work though, right?
You do.
I mean, are you finding that any of this, we get more information as information get us there? I mean, where's the will inside of people? Is that changing? Is the awareness? Is Robert Kennedy Jr., has brought a lot of attention to making America healthy again? Does that attention turn the dial at all towards?
I think
maybe I got to do something with my life.
You're spot on, because one, knowledge is power, but knowledge is only power if action comes from the knowledge.
Right.
Right. And so our model is educate, empower, and teach. But then from there, prescription intervention is still a part of medicine. And this is where I do disagree with a lot of the folks on the GLP-1s. Like the GLP-1 weight loss drugs, Wegovy and all these tirzepatide, they are a tool in the tool belt. And when utilized appropriately, can be life-changing for people.
Mm-hmm.
Absolutely, they're overprescribed. Absolutely, they're overpriced. Absolutely, they're undereducating the patient, and they're not taking time to give them the pros and cons of these compounds. But if you can help an obese patient put wins on the board and you help them lose 10 to 15 pounds, and momentum breeds momentum, and we've seen it.
And feeling good about yourself, I mean, is just huge, right?
Oh, it's gigantic.
Yeah.
And then what you see, and I won't say names, but there's been several famous overweight people who have come to our clinics and lost a lot of weight and have talked about it. Like, I mean, Jelly Roll's talked about it on the Rogan podcast.
Mm-hmm.
Several big name comedians that we've helped lose a ton of weight. And now they're like fitness guys.
Yeah.
Like they're working out every day. They're eating clean.
Wow.
But it starts with putting wins on the board. Our food is, I mean, Callie does an eloquent job of laying out how big tobacco went in and acquired big food in the 80s. And that encouraged them to, use those same scientists to make our food more addictive, more toxic, more abusive. And so we're in a system where throughout there's little booby traps set for us. And how do we help people break out of that matrix? I think it's educating, it's having the discussion, it's giving them the tools in the tool belt, and it's helping build momentum. And momentum doesn't mean they have to be on a prescription drug. Like one is the hormones. Like men and women over the age of 40 who have never had their blood work done because the system doesn't do it are at a severe disadvantage. They're tired, they're lethargic, there's a precipitous decline in their hormone levels, and now they're eating chemically laced addictive food products that increase their hunger urges, caloric dense, nutrient weak foods, and they're already overweight and they're depressed and they just are trying to make it through the day.
Yeah.
And that sounds like a dark picture, but I cannot tell you how many people you put them on hormone optimization and you get them back to where they were in their 20s. The upside is tremendous and the downside is pretty much non-existent. All of the stuff that we learned from the Women's Health Initiative that scared women out of hormones has been debunked and proven to be an absolute fallacy created by Big Pharma to push you to way more profitable prescription drugs. Because guess what? If a woman's not going on estrogen over the age of 40 when she's postmenopausal, she's going to have hot flashes. Now you got to get her on a hot flash drug. She's going to need to protect her bone mineral density. Now you got to put her on a BMD drug for like Fosamax to maintain and prevent osteoporosis. That's why a woman's on 4 or more prescription drugs. Same thing with men. Men now have low testosterone, their bone mineral density declines, their lean muscle mass declines, metabolic disease increases, increased abdominal fat increases. You start putting on body weight, you have low energy. Oftentimes you're depressed, you have anxiety. All of these things lead to you going on more prescription drugs.
Right.
And if we optimize hormones, and that can be through diet, lifestyle, nutrition, but you can only get so much over a certain age. And that precipitous decline is creating a cascade effect. And so dirt cheap things like hormone optimization in your 40s, 50s, 60s prevent the cascade effect of chronic disease. And so I say this, like the cancer you develop in your 50s started in your 40s.
Right.
The diabetes that you get in your 40s started in your 30s. If we go back to that proactive, predictive, preventative care model, we can offset the progression of these chronic diseases with generic medications that have been on the market for 100 years. Like testosterone's been on the market since the 1920s. It is a excellent tool in the tool belt for men to offset and fight chronic disease and practice preventative care.
When you look at the future, I mean, AI is going to wipe out, a lot of these doctors. Yeah, one doctor's going to do 100 patients instead of 6. I don't know. Do you have kids?
I don't.
Okay.
Don't.
If you were going to recommend to somebody, what should my kids go to college to study? Like, especially if I have a child that has a propensity towards wanting to heal, like wants to make a difference in the world. Number one, what jobs are going to be left there and where will they actually be effective?
It's mind-boggling. It's so funny you bring that up. I'm terrified.
Yeah.
I mean, I'm working with a large language model, and I do look at what disruption it causes. And then I also invested in, humanoid robots, Figure AI, Tesla. These humanoid robot capital are going to displace so many jobs. I I I don't have an answer to that question. I look at it and I go, it's scary, but then I look and go, when we invented the washing machine and the dishwasher, people were like, when we invented the automobile, in a way, humanity finds a way to evolve for better or worse. I mean, I do think that social media has done a lot of damage to polarize us as a species, to create these adversarial, combative tribes that we've become. And it is scary to think what happens with large language models and jobs. And that's where healthcare gets even scarier, because think about it. If less people are employed, then that becomes more people on the government tit, candidly, that need these healthcare alternatives. And we, the taxpayers, how much money is being generated? Like, all these big conglomerates are going to go to, machine learning and machine functioning, like, day-to-day business.
Going to pay for those people? I mean, I honestly, when you look at where we're going, all these right now, I just saw Mike Rowe speak the other night at an event in Washington, D.C., and he got up and said there's 7.5 or 7.6 million jobs available right now as we speak, trade jobs, and there's 7.5 million work age, healthy men at home not working. I'm assuming playing video games and, probably smoking weed.
Yeah.
And I just keep asking myself, and then I run into people that are like, oh, AI is amazing, usually ones that are investing in it.
Yeah.
And they'll say, oh, we'll figure out we find a way, and they bring up the same thing, the dishwasher, the automobile. Well, the horses went out, but I really feel like we're lying to ourselves. I just don't see, what is universe going to be? Like, battle of the prompter? Who prompts AI better than somebody else? I mean, how many jobs are going to be there? And robots come in and start actually doing the physical work. And then and then somebody recently said, I could hear like the harps from heaven as he's like, we're just all going to work less. It's going to be amazing. And I was like, no way.
I literally have these conversations.
No
it's
way.
Terrifying to me, because I look at my company and I employ, I think, almost 300 people. Last number was 275. The amount of human capital it takes to be able to bring forth and do what we're doing is staggering. But 5 years from now, that's not the case.
Yeah.
And so, the idealist in me goes, but we'll grow and we'll find new ways. And as we grow, it'll just allow me to bring comprehensive care to the masses for cheaper and scale better and more efficiently, and drive down the cost of drugs and prescription medicine and prescription care and blood work and algorithm-based. That's the optimist in me. But the other side of me goes,
who's buying?
Where are all these people going to go, and who's going to employ all these people? Because it's not just the naive part is people think it's factory workers and all. No, who's going to lose jobs are accountants, attorneys,
lawyers,
doctors. 100%.
Yeah.
ChatGPT today can do a better job than most clinicians.
And forget about
really
attorneys.
can.
Like, the whole deal is to find previous cases that, you know what I mean, and look at precedents. AI is going to be amazing at that.
Yes.
And so then I just imagine when people are like, oh, we're all going to work less. Well, that'd be great. Except that in my experience, that tiny group of people that do the work or do make the money or end up being the world's greatest AI prompters, so that they've risen to the top and maybe got into the pyramid scheme, if you will, before everyone else did, they rise up. But then you have this whole body of people not working, and that group is going to say, hey, let's just vote to give them more money hanging home. I think they need a raise. I think the guy like playing video games and smoking weed and eating Doritos and drinking Coca-Cola, I think he needs a raise this year. I mean, I don't know what people are thinking.
Sam Altman wrote a manifesto that's like 7 years old at this point. I can email it to your team.
Yeah.
It's pretty terrifying.
Is it?
Because this manifesto that he wrote was basically him predicting the future and saying, as large language models and machine learning grows, we will need to transition to a universal income, and there will be a massive amount of jobs displaced. And at the time, he was predicting within 7 years. And I think that it's like 5 years ago, and AI is moving so fast, and large language models and all, and innovation will come from that too. It's a very complicated thing.
Yeah.
It's very, and like every single thing we do, it creates, I mean, I love the show Black Mirror. Have you ever seen Black Mirror?
I think I've seen an episode.
I think it's on
Yeah,
HBO.
yeah,
It takes like technology or something that's positive, but it takes a dark angle on it. Like every problem you create does create a counter issue.
Yeah.
Every problem we solve creates an array of new problems. And these technologies are going to displace a massive amount of jobs. It's going to cause it to be a disruption to healthcare.
Yeah.
Like, you know, my wheelhouse is healthcare. I just look at what it's going to do to the people who are employed in the healthcare space, but then also this entire money grab system that the insurance companies and big pharmaceutical companies have built to try to monetize chronic disease. That system doesn't work when people don't have jobs where their employers are technically the ones really fitting the bill for their healthcare. If people have to come out of pocket, they're real frugal with their spending. And that's where I do go back to an HSA and go, if we gave people a budget and tax incentives to get healthy and drive their own health, take it out of the hands of the insurance companies and let them drive their own. But it doesn't fix the problem if we have to go to universal health care. Like, what do we do?
I mean, and you know, universal income, I think that all I know is you don't want to be one of the more expensive ones on the system.
Yeah.
You know, as they start trying to figure out who's paying for what. And honestly, think of how the insurance companies are running things as you are, pharma. Those are the oligarchs. Those are who are going to end up deciding how much we give those of you that aren't working, how much we're going to take care of you. So far, they haven't been, you know, very benevolent. And I think that, I think it's a good incentive anyway to get your health in order, you know, live the most spectacular life that you can right now. Take it under your own control. Because as we hand over our life right now, I think it's going to be shocking what happens in the next year, you know, a few years if we make decisions, say, hey, you handle it for me, let the government handle it for me, let the insurance companies handle it for me, they might start making some decisions we're not too happy about.
No, I say that. You literally paraphrased what I try to say all the time. If you put your health and your family's health in the hands of these big insurance companies, and you eat the average American diet and you go to the average American doctor, do not be shocked when you die of the average American chronic disease. Yeah. That is what the system is built to do. You've got to take yourself out of the system. And we can wish in one hand and shit in the other and see what fills up first. But right now, it's like you're going to have to come out of pocket and drive your family's health until Bobby and this new administration hopefully make the change that I know Bobby's hoping to drive. And that's how I got affiliated with MAHA, was me. No. He was the first politician to ever sit down. One of his folks heard the Rogan podcast. I had the privilege of getting to know Tulsi just because of Joe. And Tulsi was fascinated by it and was like, you've got to get political. You've got to raise the voice on what's going on. And she was an advocate for the things I was saying. And then randomly I met Bobby and he sat down literally for like 40 minutes and just picked my brain.
Yeah.
And other than Tulsi Gabbard, he was the first politician I've ever met that seemed to actually give a shit about what's going on. Like, to his credit, he truly seemed to care and want to understand it and want to fight it. And that's where I'm excited. Like, at least we're having, because again, in medicine, we can't cure what we don't diagnose. At least we're at a point where we're starting to diagnose the problem, right? That's more than we've ever done in the history of our government, is at least we're finally diagnosing the chronic disease. Now the question is, can we cure it?
Yeah. Amazing. Brigham, thank you for taking the time to share with us. I mean, honestly, some real revelations for me, because, you know, as we look at MAHA, all I want to do is, how do we build that ecosystem for health? Proactive, preventative, and to know that, you know, in some ways you're being thwarted by big systems that are like, no, we're not going to let you do that. We're not going to pay for that. You know, we'll pull, like, the idea that insurance, you know, carriers are going to pull out from doctors that are trying to actually heal you and help you. There's a lot of work to do, but that's where I feel like we've got to remember that the government in this country, in America, is just our representatives, like our power, what we want, what we decide. I think it's, companies like yours and taking our health into our own hands, getting proactive. Let's build the system outside of the government so it doesn't end up having to make those choices for us.
I love it.
All right.
That's my vision too. So I
All
hope
right.
that we can build a life raft, and I hope that we can fix the system. But we're down the right path because at least we're talking about it.
Amen.
Yeah.
All right.
Thank
Keep
you,
up the
man.
Good work.
Appreciate you.
Catch you soon.
Yeah.